Hi, dear friends. I'm Dr. SHISHIR AGRAWAL from Apollo Medics Hospital, Lucknow. Thank you, AORA, for providing me this stage. Today, I will be talking about anesthesia in patient on antithrombotic drug. So, a lot of patients we are facing who are on antithrombotic drug, they they come for elective surgery or the emergency surgery. They are on antithrombotic drugs for various reasons, maybe prevention and treatment of coronary artery disease, venous thromboembolism, stroke, post atrial fibrillation, or after the any valve replacement surgery. So, what to do, how to manage, what are the challenges? Let us see. One side, there is a advanced surgeon who want to perform surgery at any condition, and another side, we anesthesiologists, we are in dilemma on what anticoagulant he was, when was the last dose given, what was the indication, when to stop, when to resume. These are the all issues. Basi- But basically, why we are so much worried about these drugs? We are worried about for the epidural hematoma. Incidence of hematoma is 1 in 2.2 lakh with the spinal uh, injection and 1 into 1.5 lakh with the epidural injection. This incidence of hematoma is higher in patients who are on anticoagulant and which may be 1 in 1 lakh for spinal and 33 in 1 lakh for the epidural injections. So focus of our anesthesiologist is on uh, focus of us is on to prevention of this epidural hematoma and prevention of thrombosis, because if we stop these drugs very early, there is maybe risk of thrombosis. And also we should focus upon early detection and management of the epidural hematoma. For this American Society of Regional Anesthesia, they have framed guidelines, consensus guidelines. First guideline came into the light was in 1998, which was only focus about neuraxial block. Subsequent guideline in 2003, it was also focused upon neuraxial block. In 2010 guideline, plexus block were also be covered. In 2018 guideline, basically it was focused on intervention prone pain procedures and the regional anesthesia techniques. In 2022, ISRA recommendation came into the light with the detailed guidelines for anticoagulants. In 2024, there was some changes in the guidelines. Otherwise, the basically the 22 guidelines, it remains as such. So two major changes in this guideline was there was focus on concentration of anticoagulant drug, and second, uh, therapeutic and prophylactic doses were changes to low doses and high doses of anticoagulant drugs. So these guidelines are based upon T half of the anticoagulant drugs. After T half, only 50% of the anticoagulant it remains into the circulation. While after the second T half, 25% of the original given drug remains into the circulation. After the fifth T half, only 3.125% is the active anticoagulant in the circulation. So in those patients who are on prophylactic drugs, prophylactic anticoagulant doses, only 2 half-life interval before any neuraxial intervention is sufficient. But in patients who are on therapeutic anticoagulant or high-dose anticoagulant, these anticoagulant has to stop 5 for the 5 half-life before any neuraxial interventions. These interval can be also depend upon renal functions. Suppose if renal functions are poor, excretion may be delayed and the effect will be higher of the anticoagulant. So further delay may be required. Next thing, when to resume the anticoagulant drug after the catheter removal or after the neuraxial interventions, any neuraxial. Basically, catheter removal and epidural placement, they are equal in this, if we compare risk of the bleeding and hematoma formation. So basic idea of when to resume is the peak effect of anticoagulant should fall only after the clot stabilization. We assume that clot stabilization time is 8 hours. So when to resume the next dose is 8 hours, which is clot solidification time minus peak effect of anticoagulant. One example is here. Suppose enoxaparin peak effect is around 4 hours. So when we can give subsequent dose 8 hours minus 4 hours, that is 4 hours after the neuraxial interventions. Suppose if there is any traumatic puncture in those patients, this should be further delayed. The basic hemostasis concept after any vascular injury, there occurs three things. One is the vasoconstriction, then the primary platelet clot formation, which is unstable clot in the presence of von Willebrand factor and fibrinogen. Another is activation of coagulation cascade, which leads to conversion of fibrinogen to fibrin, and ultimately final clots, stable clot forms. Here we can see this is the factor 10 onward is the common pathway. Factor 10 is activated to 10A in the presence of calcium and either factor 7A through extrinsic pathway or factor 7A through intrinsic pathway. In presence of factor 5A, this factor 10A converts prothrombin to thrombin. This thrombin, it converts fibrinogen to fibrin, which is very important for stable clot formation. There is antithrombin, which is naturally occurring anticoagulant, which stops formation of thrombin. Heparin and low molecular weight heparin, they bind with the antithrombin and they augment the effect of antithrombin. Fondaparinux, it binds with factor 10A. Rivaroxaban, edoxaban, and apixaban, it also binds with the factor 10. While dabigatran, argabatran, bivalirudin, they are direct thrombin inhibitors. And dexamethasone alpha, it mimics factor 10 and it binds with these drugs, and so anticoagulant effect is reversed. While for dabigatran, there is a specific antidote, which is idarucizumab, which is monoclonal antibody, which binds with the dabigatran. Similarly, there are a lot of antiplatelet drugs depending upon receptors, like basic one, aspirin, which binds with thromboxane A2. P2Y2 receptors inhibitors are the phenylpyridine drugs, ticlopidine, clopidogrel, prasugrel, and reversible drugs are ticagrelol and cangrelol. These clopidogrel and prasugrel, they are prodrug which is converted to active drug by the cytochrome 450. While GP2B3A receptors antagonists are abciximab, tirofiban, eptifibite. Phosphodiesterase inhibitors are dipyridamole and cilostazol, which blocks conversion of cyclic AMP to AMP. And another group of drug is vorapaxar, which binds with the PAR1 receptors antagonist. In 2022 guidelines, anticoagulant should be stopped for the deep block, while for the superficial nerve block, we need not to stop anticoagulant before any neuraxial intervention. So how they are divided in deep and superficial block? Though in those blocks where consequence of bleeding is significant, like in sauce compartment block or epidural injections, their consequence of bleeding is significant. Or if they are so deep that um, vessels are non-compressible, you cannot stop bleeding by compression only. So in these patients, withdrawal of antithrombotic or block is required. So here you can see infraclavicular is a deep nerve block, as well as stellate ganglion block is a deep nerve block. So here I have compared all the anticoagulants and antiplatelet drugs. Heparin, it binds with factor 2, 9, and 10. T half is 1 to 2 hours. Investigation for specific for heparin is heparin level, APTT level, and when the dosage of heparin is given higher, then ACT levels should be assessed. These drugs are basically used for various interventions: coronary artery disease, pulmonary embolism, and for the DIC. And heparin is reversed by the protamine. 1 milligram of protamine is sufficient to block 100 unit of heparin. Low molecular weight heparin, it binds with the antithrombin and factor 10. T half is 4 to 7 hours. To assess the anticoagulant effect of the low molecular weight heparin, we investigate anti-factor 10 level. And these drugs are basically used for the prevention and treatment of venous thromboembolism. Low molecular weight heparin are partially reversed with the protamine. Fondaparinux, it binds with the factor 10A, T half 17 to 21 hours, and specific investigation to assess the fondaparinux effect is anti-factor 10A level, used for prevention and treatment of thromboembolism, and there is no specific reversal agent for fondaparinux. Warfarin basically blocks with the it blocks vitamin K enzymes, so and inhibits formation of vitamin K dependent clotting factors. T half is around 40 hours, and for a specific investigation to assess warfarin activity is PTINR. Warfarin is basically used after the valve replacement, deep vein thrombosis, and atrial fibrillation. Warfarin can be reversed with the vitamin K, 4-factor prothrombin concentrate, and fresh frozen plasma. Ecosprin, as we all of know that it blocks COX-1 and thromboxane A2. T half 15 to 20 minutes. A specific investigation is none. Mostly it is used for prevention of the coronary artery disease and the stroke. There is no specific reversal agent for the ecosprin, but there is some activity of desmopressin which increase VW factors level. So it can be partially recovered with the desmopressin. Similarly, clopidogrel, prasugrel, they are prodrug and P2Y12 inhibitor. They binds irreversible. Cytochrome 450 is required to convert these prodrug to active drug. So there is genetic variation in few patients. Sometimes up to into around 30% patients are non-responders for clopidogrel. T half of clopidogrel is 6 hours, while T half of prasugrel is 7 hours. And there is no specific investigation to assess level of activity of clopidogrel and prasugrel. Basically, these drugs are used for prevention of coronary disease, stroke, and therapeutic disease for coronary artery disease. And there is no specific reversal agent for these P2Y12 receptors. Only desmopressin has some activities. It has some role. Similarly, ticagrelor and cangrelor. Ticagrelor has T half around 2 hours, while cangrelor is very short acting. T half is around 2 to 5 minutes. These drugs are cangrelor is basically used for coronary interventions. One thing which is very important, after cangrelol, we cannot give clopidogrel and prasugrel because receptors are already occupied by the cangrelol, while ticagrelol we can give because there is a separate receptor for ticagrelol. Dabigatran is direct thrombin inhibitors, T-half 12 to 17 hours. Very specific investigation to assess dabigatran activity is diluted thrombin time. This drug is basically used for prevention of stroke after the atrial fibrillation and treatment and prevention of deep vein thrombosis. There is a very specific reversal agent for dabigatran, which is idarucizumab. There are other drugs which are direct acting factor 10A inhibitor. These are apixaban, rivaroxaban, and edoxaban. These drugs are very commonly used for prevention of deep vein thrombosis and prevention of stroke in AF patients. Half-life of apixaban is 12 hours, rivaroxaban 5 to 9 hours, edoxaban 10 to 14 hours. And a specific antidote for these drugs are reversal agent are adexanate alpha. Tirofiban, aptifibide, abciximab, these are GP2B3A inhibitors. They blocks platelet they reduces platelet function. They block platelet receptors. T-half of tirofiban is 2 hours, aptifibide 2 to 4 hours, abciximab 30 minutes. Basically, these drugs are used for percutaneous coronary interventions. The specific investigation to assess activity of these drugs is ACT. And there is no specific reversal agent for these drugs. Now, the most important part of the guideline, when to stop anticoagulant and when to resume these drugs after the neuraxial interventions. IV heparin or heparin infusion should be stopped 4 to 6 hours prior neuraxial intervention and can be restarted 1 hour after the spinal injection. Coagulation level should be assessed. In presence of the IV heparin, catheter should not be placed and should not be maintained. In presence of already if there is already a placed catheter and there is unanticipated exposure of heparin, in these patients, motor function should be evaluated to early detect epidural hematoma. For heparin subcutaneous injection, this heparin subcutaneous injection should be stopped 4 to 6 hours prior to the neuraxial procedure and can be resumed immediate after the spinal epidural procedure. In those patients who are on unfractionated heparin for more than 4 days, platelet count should be measured because there is a risk of heparin-induced thrombocytopenia. Patient on high dose of heparin where dosage is less than 20,000 should be stopped 12 hours prior to the epidural injection and can be resumed 12 hours after the injection. But the catheter should not be maintained in presence of high dosage of heparin. When the heparin dosage is very high, more than 20,000 units per day, it should be stopped 24 hours prior to the neuraxial interventions and can be resumed only 12 hours after the procedure. But before any neuraxial interventions, APTT should be within normal limit. Low molecular weight heparin, which is defined as deltaparin 5,000 units or enoxaparin 40 mg per day or 30 mg BD, should be stopped 12 hours prior to any neuraxial intervention and can be resumed 4 hours after the spinal epidural injection. But if there is a bloody tap, one should avoid giving low molecular weight heparin for next 24 hours. For the low molecular weight heparin, those who are on high dose is defined as deltaparin 200 international unit per kg per day or enoxaparin 1.5 mg per kg per day or 1 mg per kg per day BD. In these patients, LMWS should be stopped 24 hours prior to the procedure and can be resumed 24 hours after the procedure. And alternatively, we can assess anti-factor 10A level. It should be less than 0.1 international unit per ml. But in case of bloody tap, this should be this high doses of LMWS should be hold for 48 to 72 hours. Warfarin, as all of we know, should be stopped 5 hours prior to any neuroaxial intervention and should not be started in presence of the catheter. But before any interventions, INR should be less than 1.5. Fundoparinox, low dose, should be stopped 36 hours prior to the neuroaxial interventions, can be resumed 6 hours after the intervention. Alternatively, we can assess anti-factor 10A level, which should be less than 0.1 international unit per ml. In those patients who are elderly, this interval should be more than 42 hours. But if the creatinine clearance is between 30 to 50, this interval should be gap between the last drug dose and the neuroaxial procedure should be more than 58 hours. When the creatinine clearance is less than 30, in these patients, there should not be attempt any neuroaxial procedure. For the fundoparinox high doses, it should be stopped 70 hours prior to the neuroaxial interventions and can be resumed 6 hours after the neuroaxial interventions. Alternatively, in these patients, anti-factor 10A level should be assessed before any neuroaxial procedure. It should be less than 0.1 international unit per ml. For elderly patient, this interval should be more than 105 hours. Apixaban, low dose should be stopped 36 hours prior to procedure, can resume 6 hours after the procedure. Rivaroxaban, low dose should be stopped 24 hours prior to procedure, can be resumed 6 hours after the procedure. But in those patients where creatinine clearance is less than 30, interval should be more than 30 hours. In patients on dabigatran low dose, it should be stopped 2 days prior to the neuroaxial procedure and can be resumed 6 hours after the procedure. But with the high dosage of apixaban, edoxaban, rivaroxaban, and dabigatran should be stopped 3 days prior to the neuroaxial intervention, and this drug can be resumed only after 24 hours after the catheter removal. Dabigatran is creatinine clearance sensitive drug. So if creatinine clearance is between 30 to 50, this interval should be more than 120 hours. And if creatinine clearance is less than 30, neuroaxial intervention should be avoided in these patients. Neuroaxial interventions are acceptable if plasma level of apixaban, edoxaban, rivaroxaban, or dabigatran level is less than 30 nanogram per ml, or anti-factor 10L level is less than 0.1 international unit per ml. For ecosprin, low dosage means less than 200 milligram. There is no need to stop ecosprin before any neuroaxial interventions and can be resumed immediate after the neuroaxial procedure. But for ecosprin high dosage, it should be stopped 3 days prior, and can be resumed 6 hours after the epidural injections. Clopidogrel should be stopped 5 to 7 days prior to intervention. Prasugrel should be stopped 7 to 10 days prior to intervention. Ticagrelol should be stopped 5 to 7 days prior to interventions. Ticlopidine should be stopped 10 days prior to the neuroaxial intervention. But these drugs can resume immediate after the spinal epidural or deep plexus block. But if it requires loading doses of clopidogrel, prasugrel, and ticagrelol, this gap between the neuroaxial interventions and the next dose should be more than 6 hours. For prasugrel, catheter should not be maintained because onset is very rapid and it is very effective anticoagulant. And for the ticagrelol, catheter should not be maintained, and cangrelol is a very short-acting drug, so it should be hold only for the 3 hours prior to the any interventions and can be resumed 8 hours after the neuraxial intervention. But catheter should not be maintained in case of cangrelol, who in those patients who are on cangrelol. Abscessimab should be stopped 24 hours to 2 days prior to the neuraxial intervention, can be resumed 24 hours after the deep block. And it should not be restart in presence of the epidural catheters. Eptifibatide should be stopped around 4 to 6 hours prior to neuraxial interventions and can be resumed 24 hours after the neuraxial intervention. These drugs are contraindicated for 4 weeks after any surgery. Tirofiban should be stopped 4 to 6 hours prior to the neuraxial interventions. Can be resumed 24 hours after the procedure. Silastazole should be stopped 2 days prior to the interventions and can be resumed 6 hours after the interventions. But before any neuraxial interventions, platelet function should be within normal limit. With the bivalirudin and ergabatron, neuraxial intervention should not be performed. For thrombolytic drugs like etaplase, streptokinase, and letiplase, it should be stopped around 2 days prior to the any neuraxial interventions and can be resumed only after 24 hours after the catheter removal. In case if there is history of vessel puncture, these thrombolytic therapy should be avoided for 10 days. And in these patients, neurological monitoring is must for next 48 hours for early detection of epidural hematoma. For any neuraxial intervention, fibrinogen level should be within normal limit. What about herbal medication? So guidelines says it should not be discontinued before any neuraxial intervention. This was all about elective surgery, but what in cases of emergency patients who came for emergency surgery? For this purpose, European expert consensus has framed a guideline. So if there is a major anticoagulant related intracranial hemorrhage or GIT or trauma related bleeding, this will suggest what to do in this situation. So for this, there are certain steps. Step 1 is identify the bleeding. See if there is a severe bleeding. Severe bleeding means if the site of bleeding is very important, like if it is intracranial bleeding, pericardial bleeding, retroperitoneal bleeding, or if there is hemodynamic instability, like there is hypotension or tachycardia, or there is some risk of compartment syndrome and limb-threatening hematoma is there. If severe bleeding is present, so we should go for step 2. Step 2 is the resuscitation. We should activate ATLS. Anticoagulant should be hold. We should try our best with the basic maneuvers like compression, endoscopy, various other maneuvers we can do to stop bleeding. Tranexamic acid 1 gram should be given. Tranexa 1 gram should be given in all the trauma related without seeing efficacy of the drug. Now the step 3 is determine the effect of anticoagulant. Suppose patient is on warfarin, confirm recent treatment. If patient was on warfarin, when was the last dose was given and how much drug was given. Measure the INR level. If INR level is 1.2, there is no residual effect of warfarin. If it is between 1.2 to 1.5, there is unlikely any effect of warfarin. If the INR is more than 1.5, there is likely residual effect of warfarin. In patients on oral coagulant like dabigatran, apixaban, indoxaban, and rivaroxaban, take a proper history, confirm the drug, dose, and last time when the drug was received. If the last dose was given in less than 24 hours prior to emergency admission, these investigations should be done like PTINR. If PTINR is abnormal, it means there is certainly residual effect of the anticoagulant. But if the PTINR, it comes within normal limit, it does not exclude, there is no effect of anticoagulant. Similarly, for the APTT, if APTT is abnormal, it means there is residual effect of the anticoagulant. But if the APTT level are normal, it does not exclude, there is no residual effect of anticoagulant. Thrombin time should be done to assess the activity of dabigatran. If it is normal, it means there is no residual effect of dabigatran and it is not relevant for apixaban, rivaroxaban. Anti-factor 10A level should be assessed, which is not relevant for dabigatran, while this anti-factor 10A level less than 0.1 international unit per ml shows there is no residual effect of rivaroxaban. But if this anti-factor 10A level is more than 0.1 international unit per ml, there is a likely effect of the rivaroxaban. And very specific investigation are diluted thrombin time for the dabigatran and a specific calibrated anti-factor 10A activity for apixaban, edoxaban, and rivaroxaban. If the level is less than 50 nanogram per ml, there is likely no effect of rivaroxaban. And if this effect, level is more than 50 nanogram per ml, it shows significant anticoagulant effect of these drugs. But treatment should not be delayed till we are waiting for the investigations. Step 4, if there is certain signs of the bleeding and based upon these investigations, if there is clinical significant effect of anticoagulant, we should go for reversal. So now let us see how to reverse these anticoagulants. Those patients who are on thrombolytic therapy, if the last dose is given less than 24 hours prior to emergency admission, reversals should be done using cryoprecipitate more than 10 unit with the basic idea to get the fibrinogen level more than 150. So fibrinogen level should be more than 150 after cryoprecipitate transfusion. And at the same time, the Nexa should be given around 10 to 15 milligram per kg. For antiplatelet drugs like aspirin and clopidogrel, if there is a bleeding and emergency surgery, it should be reversed using platelet. Single donor platelet should be given. But there is a catch. Clopidogrel, if it is given if clopidogrel is given in less than 24 hours, it is irreversible binds with the platelet. So there is, if plasma concentration of rivaroxaban, clopidogrel is there in the blood, it will binds with the circulating platelets. So transfused platelet will become also ineffective. Desmopressin can be given, dosage is 0.4 microgram per kg. Desmopressin basically it activates VW factors. But there is a catch. Desmopressin is available on as a nasal preparation, intranasal preparation in India only. IV preparations are not available in India. Unfractioned heparin hepatitis should be assessed. And if the therapeutic dose was given, it should be reversed using protamine 1 milligram for 100 units. For low molecular weight heparin, anti-factor 10A level should be assessed. If it is more than 0.1 international unit per ml, it should be reversed with the adaxanate alpha. Adaxanate alpha is the first choice. So bolus should be given 800 milligram followed by 960 milligram over a period of 2 hours. Protamine is the second choice. If LMWH is given within 8 hours, dosage of protamine is around 1 milligram per kg. If it is given between the 8 hours to 12 hours prior to emergency admission, its dosage of the protamine is around 0.5 milligram per kg. For warfarin, in all patients, vitamin K should be given 5 to 10 milligram IV. 4-factor prothrombin concentrate is the specific drug for the warfarin. It is very specific for warfarin, and it is the first choice. If weight and INR of the patient is not available, 2000 unit test should be given. But if INR is available, if INR is between 1.5 to 3, 1000 unit of the vitamin K, 1000 unit of 4-factor PCC should be given. If INR is between 3 to 5, 2000 unit of PCC should be given. If INR is more than 5, 3000 international unit of PCC should be transfused. Based upon INR and body weight, if INR is between 2 to 4, 25 international per kg, between INR between 4 to 6, 35 international unit per kg, more than 6, 50 international unit per kg. FFP is basically it is an alternative therapy when PCC is not available. Doses are 10 to 30 ml per kg. But the drawback, there is a risk of transfusion overload, and it onset is relatively slower. Dabigatran can be reversed with, as we know, idarucizumab, which is monoclonal antibody. Total doses are around 5 gram, which should be given in two divided doses of 2.5 gram bolus. Off-label use can be activated prothrombin concentrate or 4-factor PCC. 4-factor prothrombin concentrate can be given in dosage of 2000 units. For 10 inhibitors, if 10 inhibitors are given within 2 hours, we can give active charcoal by dialysis tube or by the oral route. So for apixaban, rivaroxaban, and edoxaban, time of last dose is very important. If it is given, this interval is more than 8 hours, we will consider low dose of adexanet alpha. But if this interval of last dose and the bleeding, it is less than 8 hours, we will see what was the dosage given. For apixaban, if last dose was given less than 5 milligram, we should give adexanet alpha low dose. But for the high dose, like 5 milligram per kg, and if it was given within 8 hours, so high dose of the adexanet alpha should be given. Similarly, for the rivaroxaban, less than 10 milligram, low dose should be given. More than 10 milligram, high dose should be given. And if the time interval is less than 8 hours. For edoxaban, less than 10 milligram and time interval less than 8 hours, low doses should be given. If doses are more than 30 milligram and time interval is less than 8 hours, high doses should be given. High doses means 800 milligram IV bolus followed by 960 milligram infusion over a period of 2 hours. Low dose means 400 milligram IV bolus followed by 480 milligram IV infusion over a period of 2 hours. 4-factor PCC also can be given as basically it is a second choice, or it can be used as off-label drug. Dosage is around 2000 units. So after the reversal of anticoagulant, we should assess that either this bleeding is stopped. Yes, if bleeding is stopped, we should assess the indication of anticoagulant. What was the indication? Can we stop anticoagulant, or we have to resume anticoagulant? We should assess risk-benefit ratio. Should we continue anticoagulant after this bleeding, or should we stop? And before restarting anticoagulant, patients and caregivers should be in the decision making. Then the next steps is we should assess how can we prevent future bleeding. So we should assess the renal function, age, weight, and should optimize drug accordingly. we can assess like what was the other drugs which may enhance or decrease the effect of anticoagulant. So those drugs also should be modified, and other factors which are responsible for bleeding should be assessed. And also, finally, we should assess the net clinical benefit of anticoagulant during long-term follow-up. Thank you for listening me. Thank you, dear friends.